thing. So good morning, everybody. My name is Sara Dugan. I'm a psychiatric pharmacist and faculty at Neomed. I'm trying to multitask by pulling up my slides. Here we go. So our didactic topic today is to cover this journal club. Objective-wise, we're going to look just briefly at some of the data related to prevalence of post-traumatic stress disorder and alcohol use disorder. Why did they put these two together as the target cohort population? We're going to look at this review, and it highlights a number of findings related to currently available treatment for PTSD and alcohol use disorder, but then it tries to look at the treatment options. I don't know if you can hear that. Our dog tore her ACL, and I'm not sure exactly what that noise was. They just came out of her. She's laying down, so hopefully she'll be all right. So what the article does is it reviews the treatment options for PTSD for alcohol use disorder, and then it looks at the evidence that we have for treatment of both conditions. Because often for the PTSD clinical trials, it actually removes some of the patients who had substance use disorder. So this was looking specifically to try to identify that population, and then identify treatment options, specifically trying to look at, is there a role, and what might the potential impact be with the use of MDMA? So I think when I pulled the article and read the abstract, it was a little bit different than what the details were when we went through, and we'll kind of talk about that as we move forward. So this is just our roadmap for today as we walk through that article. If you are unable to access it, this is the full citation. It was published in the Journal of Psychopharmacology in 2023. So just real briefly on the background side, so post-traumatic stress disorder, continuous symptoms following a traumatic event. The authors really focused on the categories of symptoms that patients with PTSD experience. So some of those intrusive symptoms, memories, flashbacks, dreams, distress that happens from cues or triggers, avoidance of stimuli, negative alterations, so loss of memory, distorted cognitions, decreased interest in things that may potentially have some of those cues, negative beliefs, negative emotional state, some detachment, and then hyperarousal. So including some of that irritability, potentially anger or agitation, recklessness, hypervigilance. That also may result in some of the sleep difficulties as well as some of the concentration impairment. So looking at all of those, not every patient who experiences post-traumatic stress disorder has all of those symptoms, and they may present in a number of different ways. So it would be helpful if we have treatments that are able to address all of them. As we look at the treatment interventions currently, we have some that can assist with some of those symptoms, but there's room for there's an opportunity for improvement, which really is where the authors were going with looking outside the box for novel intervention, specifically with MDMA. On the alcohol use disorder side, so the frequent or heavy use, the use of alcohol being really difficult for the individual to control, that they end up using more frequently or at a heavier amount than what they had intended. And it results in impairment in the relationships of across the board. So whatever their employment situation may be, their academics may be problematic, their family and friend relationships all could be impaired as well. But there's a unique interplay between alcohol use disorder and post-traumatic stress disorder. So individuals who have been exposed to trauma, it really can result in a vicious cycle. So in some cases, the PTSD symptoms may be really distressing. An individual may be turning to alcohol as a way to assist with managing some of those symptoms. And unfortunately, increasing the alcohol use often then results in an exacerbation of some of those PTSD symptoms, which then result in additional distress where the individual may then try to continue to self-treat with the use of alcohol, thus resulting in that cycle that can really escalate pretty significantly. While the overall prevalence of alcohol use disorder is about 13% for adults in the United States over the last 12 months, lifetime-wise, it's about 30%. But when you look at the interaction between post-traumatic stress disorder and alcohol use disorder, it's well above 2/3. So while individuals may not necessarily carry the formal diagnosis, the reality is when they look at what their alcohol use is, many of them do fit that criteria, which means that there's a large cohort of patients that really would fall into this, this intersection that we're going to focus on today. Also, as I just mentioned, with alcohol being used, it has been reported in a few different trials that this is the most prevalent substance that's been used by individuals who have PTSD. I will say that there is an increasing trend with the use of cannabis as well. So we will have to see if this continues to be the most prevalent, but I also think that that may introduce a new consideration for treatment with individuals who are using cannabis, who may be also using alcohol and also are experiencing PTSD. So I think just kind of keeping that in mind, that that may be a new a new population we're going to need to pay some attention to that we haven't necessarily identified or called out specifically. So as I mentioned, we can increase the severity of those symptoms of PTSD, especially with heavy alcohol use. And when they've evaluated patients who had PTSD, overall functioning does tend to be somewhat diminished if there is increased alcohol use. So we see the increased severity of symptoms. It tends to impact their neuropsychological functioning as well as some of the executive functioning outcomes that they've been looking at. So we do see that individuals who are using alcohol fairly heavily and consistently have reduced scores, not necessarily that they're not as capable as their peers, but they really are having some degree of impairment, likely due to the combination of the two. It also has been associated with an increase in attrition. So individuals are not as likely to be maintained in treatment, nor are they as likely to continue through clinical trials. So that tends to be one of the factors that contributes to the individuals who end up dropping out before the end. The other piece that is of pretty significant concern is the risk for suicidal ideation and suicide attempts. So in individuals with post-traumatic stress disorder, the use of alcohol tends to elevate the potential risk if they have had suicidal ideation of moving that to a suicide attempt. So this is a relatively high risk population. AUD and PTSD is actually a higher risk factor for suicide attempts than PTSD alone, or than major depressive disorder. So it really elevates that risk pretty significantly, which means high risk population, looking and exploring treatment options specifically for them is probably something we should have done a little bit earlier. So the authors wanted to take a look at this. So what their main aim was for this manuscript was to summarize current treatment practices for post-traumatic stress disorder, for alcohol use disorder, and then for both PTSD and alcohol use disorder. They also wanted to, and these were their words, to contextualize the research on MDMA. So they really wanted to, essentially, they're laying the groundwork and doing an environmental scan. What do the current treatments look like? Where are the gaps? Why could we use MDMA, and how might they fill those gaps? So that really was the layout for this manuscript. So spoiler if you haven't read it. So methodology, they just did a systematic review. They were just pulling articles that looked at treatment of alcohol use disorder, PTSD, and then the combination. There weren't specific criteria. And I do have a caveat because I'll put that in a couple places. So they included treatment data for each of these cohorts, but it was not comprehensive. So they did include things like systematic reviews and meta-analyses, but they didn't include all of the data for all of the treatments that they did include. So I will include what they included, but recognize that it is a snapshot. It may not be the full picture. So, and that was my reminder to make sure I told you that, my little asterisk there. Okay, treatments. So they looked at AUD, they looked at PTSD, and then the combination. So I'm going to start with alcohol use disorder. So our 3 approved treatments, disulfiram, naltrexone, and acamprosate. With the disulfiram, they really appreciated the fact that it promotes abstinence through aversion. So with individuals feeling ill if they then ingest alcohol, they included a systematic review that looked at 11 different clinical trials with the use of disulfiram, and it was effective in promoting abstinence over placebo. So compared to placebo, patients were much more likely to be able to maintain their abstinence. But the short term was about 12 to 16 weeks. When you got beyond that, they started to see a division within the clinical trial data. Longer term efficacy if they were in a supervised environment. So if there was supervised administration of the disulfiram, they continued to see benefit. They continued to see the abstinence rates remain above placebo, although they do tend to diminish over time. For those who had longer term treatment that did not have supervised administration of the disulfiram, they did not see that. So they started to see kind of a reversion, and it was essentially equal abstinence rates to what they found with placebo. So they see this as an opportunity because not everyone's going to be in a situation where they're able to have continuous supervised administration. On the naltrexone side, they really positioned this as an agent that helps to diminish cravings. They recognize that there are kind of 2 different options. So just looking generally if naltrexone can be effective with the oral agent. So this was a clinical trial of over 118 patients. They followed them for over 6 months, and they did see an improvement. So the amount of cravings in patients on naltrexone was lower than what they saw with placebo, and the number of heavy drinking days had been diminished. So for individuals who were on naltrexone, the heavy drinking days were lowered by over 20% and up to about 35%, whereas the number of heavy drinking days pretty much did not, it had minimal change in the placebo group. So they did not see those percentages of decreases. Adherence continues to be an issue. So again, this is something that needs to be administered every day. There are some alternate oral treatment options where it can be given a couple times a week, but for the most part, that administration and adherence also was a big factor when we moved from more short-term at the 6 months to looking a little bit more long-term. So they did include data for the long-acting injection as well. So this was a clinical trial, 624 patients. They followed them for 6 months on the long-acting injection, and they also included supportive therapy, and they did see a decrease, again, in the heavy drinking days. So for patients who, they had 2 different doses of the long-acting injection. For the lower dose, they saw a 17% reduction in heavy drinking days. For the higher dose, the 380 milligram monthly, they saw a 25% reduction in heavy drinking days. So again, yes, can be beneficial, reducing the number of higher drinking days, not taking that to 0, assisting with the craving, but that adherence and maintenance still continuing to be problematic. Last agent for AUD was the acamprosate. The authors really described this as assisting with protracted withdrawal symptoms so that it can help with the symptoms, but also may assist a little bit with comfort of the patient more long-term. For this one, they included a meta-analysis that had 17 clinical trials, and they found that it promoted abstinence up to 6 months. So again, we are seeing patients able to abstain from the use of alcohol, but adherence, especially with the 3 times daily dose, after we get past that 6 months, looking more long-term continues to be problematic. So all agents that can be helpful, but long-term, we're not seeing a whole lot of sustaining impact on the efficacy. So let's pivot to PTSD. For PTSD, they focused on sertraline and paroxetine, which have FDA-approved indications. For the sertraline, they broadly identified that it can be beneficial. So it can improve symptoms kind of across the board in all of those categories, the re-experiencing, the avoidance, the hyperarousal. We do see improvement compared to placebo in individuals who are on the sertraline. We see a reduction in symptom intensity. They kind of generally talked about comparison to placebo and a reduction in intensity after about 12 weeks. But they also highlighted the fact that long-term, some of the psychological interventions like prolonged exposure were more beneficial than the sertraline. Overall, when you look at the use of sertraline for treatment of PTSD, we can see that the majority of patients do respond. Their CAPS score tends to be reduced by an average of about 30 points. So that tends to be right at the threshold for having clinical response. So across the board, it does appear to be beneficial. Does it take everyone to remission? No. No, it does not. And there do appear to be some cohorts of patients with PTSD who respond a little bit better than others. For paroxetine, they again saw improvement in symptoms overall. There were some pilot studies that they included. They include one of the 3-month trials. They saw that it was comparable to cognitive behavioral therapy. But again, long-term, the cognitive behavioral therapy seemed to have an advantage in maintaining that efficacy a little bit more long-term. They did see some improvement in each of the categories of PTSD symptoms. And there was one trial that they included that also looked at mitigating the onset of PTSD. So for individuals who were exposed to a traumatic event when they were administered paroxetine ahead of time, so before they developed any of the symptoms, they did see improvement in quality of life as well as social functioning after that. So it did appear to have minimal improvement. It wasn't long enough to be able to determine fully if it was going to prevent the onset of PTSD, but it may have kind of a unique role in that area. Taking a step back outside of the article, in general, paroxetine also tends to be found to be effective for PTSD symptoms. On average, we can see a little bit greater variety. In some clinical trials, we see an improvement of about 19 points on the CAP score, which does tend to fall just below that response rate. So between 30 and 35 tends to be where we see clinical response. So in some clinical trials, on average, we weren't seeing all of the patients meet that threshold. But in other clinical trials, you can see improvement of up to 40 points on the CAP score. So we see a little bit more variability with this. Adverse effect-wise, we also see that, so that may have some impact as well. The authors for this trial also included prazosin. So looking at prazosin as its use for sleep disturbances, specifically for nightmares. They see an improvement in some cohorts, but there is some inconsistent data, and there is a wide range of doses that do tend to be used. In some of the veteran populations, they have pushed the dose. They have been able to demonstrate improvement in nightmares as well as improvement in total sleep time. So the greatest amount that I saw was an improvement of over an hour and a half, so an average gain of more than 94 minutes per night. So could be helpful, but again, very limited in terms of the number of PTSD symptoms that they were looking at. They included topiramate as well as venlafaxine in there. So topiramate having improvement, they see an improvement in re-experiencing symptoms as well as some of the numbing, the emotional numbing compared to placebo. When you look at the average improvement in CAP scores, kind of stepping outside of what the authors did, you do see larger numerical responses. So on average, you can see improvements in the upper 30s, so 37 to 39 points. So the vast majority of patients who are on topiramate do meet that threshold for clinical response. Again, not moving them to remission, but definitely having an improvement in some of those symptoms. And then lastly, for venlafaxine, so improvement compared to placebo, it's been shown to be kind of equally non-inferior to the SSRIs, including sertraline, improvement in the re-experiencing as well as the avoidance and the hyperarousal category of symptoms. We see improvement over 24 weeks, so that has been able to be maintained. And we do see a little bit of variability, again, similar to the paroxetine. So in looking at other clinical trials, you can see average improvement scores of about 20 to 22, so below that threshold for clinical response. And then in others, you can see improvement of more than a 50% reduction in CAP score and up to an average of 40 point improvement on CAP. So really moving almost to remission for most of those patients. So again, maybe cohort specific that some patients will respond really well and others may not. So lack of consistency across the board in terms of the treatment options for PTSD. I do just want to point out they did not include any of the second generation antipsychotics in this, and they are used for patients who do have PTSD. So that was kind of something that was not included as a consideration. So let's look at the combination. So recognizing that we had those two discrete groups, is there evidence for treatment options for individuals who have both PTSD as well as alcohol use disorder? There's not much. So there was a trial with sertraline. It included 94 patients who did have both PTSD and alcohol use disorder. It wasn't all adults. They did see an improvement, so a decrease in heavy drinking days in the individuals who were on sertraline. And they found that one of the subsets, their secondary analysis, the folks who had a later onset, less severe alcohol use disorder, and early onset PTSD were much more likely to respond than individuals who had kind of an established alcohol use disorder that was of a greater severity in a later onset of PTSD. So it does look like this could be beneficial, but maybe for a specific population. There was a trial that was done for patients on paroxetine. They did not see a change in trauma symptoms compared to disipramine. There was a reduction in symptoms overall for PTSD, but it did not necessarily call out some of the specific outcomes for alcohol use disorder. So it didn't look like it was any different from the tricyclic. Is it actually an advantage over placebo? Not clearly identified. So there wasn't a really strong signal for improvement for patients on paroxetine with these two particular conditions. So not super helpful. So we had established treatment options for both of those, not a silver bullet in either case that's going to bring all of the patients to recovery, which would be the ultimate goal. When looking at the combination, those options diminish even further. When we look at some of the other agents that may have some efficacy in both places, so prazosin had just a little bit of data. So there was a 6-week pilot trial in 30 individuals, and they saw it decrease the number of drinking days. There was a 13-week trial in veterans that did not find a difference in PTSD symptoms or in changes in their alcohol use. So little bit of mixed data, we would need some additional information. When they looked at the individuals who did respond, and this is beyond just these two, they found that those who had higher blood pressure appeared to be the individuals who have some of the better responses with the use of prazosin. So it's unclear how that relationship works, but that may be the target population that would derive benefit. For topiramate, there was a pilot trial, again, a relatively small number of individuals, and they did not see a change in frequency of drinking, but they did see an improvement in some of the post-traumatic stress disorder symptoms. So they saw a decrease in re-experiencing symptoms as well as in hyperarousal. And then for completeness, pharmacotherapy is not going to be the only option. I kind of alluded to this a little bit with some of the psychotherapy options, the non-pharmacologic interventions. These definitely have demonstrated benefit. They tend to have a much more longer lasting effect. So in trials that have looked at pharmacotherapy as well as psychotherapy, once treatment has stopped and then there's a later follow-up date, the symptom improvement tends to be more consistently maintained in those individuals who have had the non-pharmacologic interventions. One of the main areas that they've seen improvement is with prolonged exposure, and this can decrease PTSD and alcohol use disorder symptoms. When they looked at prolonged exposure with naltrexone, they saw a decrease in PTSD symptoms in all of the patients. So everybody got the prolonged exposure, and then half of the patients also got naltrexone and half of the patients got placebo. So everybody with prolonged exposure had improvement in their PTSD symptoms. When you added naltrexone, they actually saw an additional benefit for the alcohol use disorder. So it did appear that that was relatively synergistic, and it did not diminish the efficacy of the PTSD improvement. There was another intervention. So Seeking Safety was a different non-pharmacologic intervention. It was combined with sertraline, and they saw an improvement in PTSD symptoms and alcohol use disorder symptoms. But when they compared the two, so everybody had an improvement, but individuals who also received sertraline had a greater improvement in their PTSD symptoms. So again, really lending some additional support to combination therapy would be best for this patient cohort. But none of them were achieving remission for all of the patients that were involved, or even for the majority of patients that were involved. So that leaves us the opportunity for new interventions, for kind of thinking outside the box. This is where MDMA comes in. So why MDMA for treatment of PTSD? Well, the thought is, so in the 1960s, MDMA had been used with psychotherapy. It was believed to help promote openness of the individual and to help with the therapeutic alliance with the therapist. It's been referred to as an actogen, so allowing individuals to, and this is directly from the paper, to reach within oneself to grasp things repressed in an altered state of consciousness, to experience euphoria and closeness to others. So it really is supposed to help take the edge off and bring them into the here and now. So potentially filter out some of the other things that are happening and allow them to be open, willing to be close with others. It does impact oxytocin a little bit, but not doing it in a state where they're more sedated. They're going to be alert and able to engage in some of the deep thinking exercises. And also open to empathy, including empathy with themselves, which may be something that they struggle with long term. So that's really the theoretical basis for why they're looking at utilizing this in different therapy type settings. Now, how would they do this in a clinical trial? They have established some criteria for what this would look like. The participants would be involved in 3 preparatory non-drug therapy sessions. So they would have at least 3 sessions before they have a session with MDMA. So in their session with MDMA, it actually lasts 8 hours where they're with the therapist over that extended period of time. There are breaks built in, and it is structured in terms of what they're going to work through. If there is distress, how they want to manage that. And that's part of what gets set up in those preparation sessions. Following an active drug session, they then have 3 non-drug sessions, really to process the information and process the progress that was made within, or process the changes that were made within that drug session. And then they would have another MDMA session, followed by 3 processing non-drug sessions. And for the clinical trials that had 3, it would be a third active treatment for that 8 hours, and then 3 of those processing sessions afterward. One of the wrinkles that comes up in this is for drug approval, the threshold that the FDA has established is compared to placebo. Well, if somebody's on MDMA versus on placebo, chances are really likely that you're going to know which group you're in. So that does make it, the unblinding really introduces the potential for significant bias. So they've tried to experiment with a few different things, trying to use different things with the placebo, including things like anticholinergics or other agents that would result in a little bit of an effect. The other thing that they've done, which also had been done in some of the ketamine trials, is using subtherapeutic doses. So you still are exposed to it, but it's not at a dose that's considered to be therapeutic. One of the considerations related to that is we haven't truly established what a therapeutic dose of MDMA is. And there does appear to be some inter-individual variability. So in one individual, a very small dose may be subtherapeutic. In another individual, it's very possible that that same subtherapeutic dose is therapeutic. They're having the effects that somebody else would have with a higher dose. So that does introduce kind of some considerations for what this then looks like. So recognizing that that's how they set up the trials, what do we have for MDMA use in these patients? So there have been trials looking at MDMA for PTSD. They have found a significant improvement in patients who had significant PTSD symptoms. These clinical trials tended to include patients, so more than 65% of the patients had failed other treatments. Specifically, they had to have failed an SSRI trial, but they often had failed more than one intervention prior to that. They did not see adverse effects associated with it. They did have significant improvement compared to the control group, but there were some fundamental methodological considerations, including the potential for bias that the FDA kind of pushed back when they were looking for approval for this at this time. They want some additional data with a little bit more rigor. So definitely a signal where they've seen improvement in PTSD symptoms, but how consistent that is and what those the framework needs to be for a treatment intervention still needs to be better vetted. On the alcohol use disorder side, there is really limited clinical evidence. So one open label clinical trial, it included 14 patients, and they did see a reduction, a pretty significant reduction in the average number of drinks per week. So patients did have to go through detox. When they presented originally, their average use was 130.6 drinks per week. They went through detox, and then they entered this intervention where they had therapy as well as MDMA sessions. They did continue to watch them. So it was 8-week intervention, 2 active treatments, and then they followed them up 9 months later. At that 9-month follow-up, they found that the patients who had used MDMA, so all of those active patients they were able to follow up with, the average alcohol use was 18.7 drinks per week. So that was a relatively significant reduction in overall use. So signal potentially for alcohol use disorder. Again, it was open label, so they did know that that was going to be what they were exposed to, but that 9-month follow-up does suggest that there had been some continued efficacy. So it seems like maybe could help with PTSD, seems to help a little bit with alcohol use disorder. Can we put them together? Yeah, there's nothing yet. So there is one clinical trial. It is ongoing. It was sponsored by Brown University. It is in adults with PTSD and alcohol use disorder. It was classified as a phase 2 kind of pilot trial, single arm. So just looking at what the active medication is going to be. It is in veterans, 2 active sessions, and their follow-up is going to be 18 weeks. So it's approximately a year, just over a year in with its recruitment. It should complete in January of 2026. So hopefully we'll be able to get some of that information soon. It was not clear if it had been impacted by any of the changes that have happened. There are a number of, when you look up the clinical trial, there are a number of alerts that pop up related to it, that it's not endorsed by the government. There's not a lot of recruitment data available compared to what previously, when you look at clinical trials, like you can see a lot more information. So it does look like it's been scaled down, but I'm hoping that they're still able to use the data that they have and then complete that with the number of patients that they were looking for. So definitely an opportunity, and they're trying to determine whether or not that would be effective. So to kind of pull things together, we don't have a lot of information. This, I feel like, oversold a little bit. I was much more excited thinking that it was going to give us more data related to PTSD and alcohol use disorder, but it really highlighted the need for additional research in this area. It also highlighted the fact that what we've been doing, we probably need to look for novel interventions, and there is a ton of interest in looking at the psychedelics, specifically MDMA. One of the other caveats is we need to make sure that those holistic outcomes, that we're looking at functionality as well as symptom scores. If we're just looking at the rating scales, that may not tell the full story. So it is hopeful that the new research that goes forward looks at both of those things. So what does that mean for those of you who care for these patients? Chances are what you've been doing is the best that we can, because we don't have established interventions. Sertraline and the prolonged exposure really had the most robust data. While numerically it wasn't always the highest, consistently it has demonstrated that both of them can improve symptoms of PTSD in most of the cohorts that they've been exposed to. And it's been done both monotherapy as well as combination. But there is the potential, and I would say keep your ears open, because they are looking at trying to add additional data in this space for the use of MDMA. That's what I've got for today.